Hey guys, so this is going to be a PowerPoint on pancreatitis. And once again, you want to pull up your GI assessment and kind of remember what the pancreas does. So just off the top of the bat, you want to write the words pancreas and then maybe draw an arrow going down saying pancreatic duct. Then you're going to have the word ampulla or vata, and then you're going to have duodenum. So this is important because your pancreatic enzymes are basically supposed to be traveling from the pancreas, and they're supposed to end up in the duodenum, and that's where they're supposed to be digesting either proteins or fat or whatever else needs to be broken down, right? So the issue is if we're having things like inflammation, or we're having obstructions or blockages, those enzymes, the pancreatic enzymes, either they're blocked off because of inflammation, or they're blocked off because of the inflammation, or I don't know, stenosis or something, or maybe even stones, and they're not able to progress. Then they start digesting wherever they're at. They back up and they start basically eating up maybe even your pancreas, let's say. So they end up creating a lot of problems for you. So we don't want that. So just trace the passage. So you have pancreas, pancreatic duct, the ampulla or vata, VATER, and then duodenum. Because when they get to the duodenum is when they're supposed to be digesting and doing what they're supposed to be doing. Right about where the pancreatic duct is, you also get what is known as a common bile duct. And remember, with the common bile duct, it was coming from the cystic duct, which the cystic duct was coming from the gallbladder. So everything kind of intertwines and meets right about where the common bile duct is. So just understand the proximity of all of that, because then if you're getting inflammation or stenosis anywhere, then you see how this could end up being a problem for everything. So the area where you have the pancreatic duct, the ampulla or vata, there's a union of a common bile duct and the pancreatic duct. They may also call that, when you're reading in your book, they may call that the hepatopancreatic ampulla. So hepatopancreatic ampulla. So now you have things like the liver, the pancreas, right, all being connected in some way. So just know that, and my point anyway is just to say that everything is really, really connected. So if you're going to have issues, then things end up being a big deal. So just get the picture, look at it, and see why this would be important to know. So once again, pancreas, pancreatic duct, ampulla vata, and then duodenum is where you want to eventually end up. All right, so they've decided to categorize pancreatitis into either acute or chronic, and you're going to see that this happens a lot of the times. And then even under the acute, they've decided to make it one mild and one severe. So we'll get to that when we get to it in a minute. So under acute, they're basically saying things like, what's going on here, laser? They're saying things like the pancreatic duct basically becomes obstructed and enzymes are backing up, and then they're causing autodigestion. Autodigestion is the key word. And then you're getting inflammation of the pancreas, all right? And then under chronic, they're saying things like it's progressive and it's an inflammatory disorder. You're getting destruction of the pancreas, and then you're getting fibrotic tissue. You're getting pressure within the pancreas increasing, and then you're getting major obstructions of the pancreatic and common bile ducts. So usually with the chronic pancreatitis, it's happening because you've been getting multiple episodes of the acute pancreatitis. So that's been going on over and over again. You haven't been treated, or maybe you keep drinking, and then it just really progresses and then just becomes severe, and then you're getting things like fibrous tissue formation. So depending on the stage you're in, the treatment is going to look similar, but it's going to look more advanced in some cases. So for instance, if you're getting definitely fibrous tissue formation, the patient may definitely need things like surgery, right? And here, maybe you're getting autodigestion, but it's not severe. Maybe if we just we halt it somehow, with maybe just the conservative treatments, the patient stops drinking, then maybe our symptoms will resolve. And I'm sure you've seen patients that drink a lot, then they end up with pancreatitis, and it's an acute pancreatitis because they've been drinking like the day before. And then they get to the hospital, they give them fluids, they rest the pancreas primarily, and then they feel better. But if it's really advanced and the autodigestion is extreme, where your blood vessels now are being lysed because of the enzymes, then that becomes a severe form of acute pancreatitis, and that treatment may look different. So just keep that in mind, that it always depends on how advanced the damage is. All right, so once again, just highlighting the different organs. So here you have a gallbladder, which I just talked about in the previous slide. Here you have the liver, and this becomes a common duct over here, right? And keeps going on. Here you have the pancreas, and here you have the pancreatic duct, and right about here everything is meeting. And remember, once again, you have your duodenum. So depending on where the inflammation, the swelling is, obstruction is, all of these different organs can get affected. All right, so pancreatitis by definition is just inflammation of the pancreas. So it can be acute and chronic. So the enzymes of interest under pancreatitis in particular, we're looking at your exocrine enzymes, right? So we're looking at things like amylase, trypsin, and lipase. They're the ones that really create the most problems for us, okay? So inflammation of the pancreas can be acute and chronic. So acute, we've already said, is a medical emergency. So depending on the severity, so you can have a high risk of life-threatening complications and mortality. Chronic may take a while to build up, and in some cases can be undetected, depending on how well your body is able to fight off whatever is going on in your body, right? So it's chronic, it's building up, so maybe you're just having a little bit of GI manifestations, nausea, vomiting, etc. But then, like I said on the previous slide, you can end up with fibrous tissue formation. At that point, it's definitely going to be life-threatening as well. All right. So acute pancreatitis usually does not lead to chronic pancreatitis unless complications develop, and we'll be talking about some of those complications. And chronic pancreatitis can be characterized by acute episodes, basically of pancreatitis itself. So they usually, when they're talking about pancreatitis, they're describing it as autodigestion of the pancreas. So the pancreatic duct, you're going to look again at your anatomy, becomes temporarily obstructed, accompanied by hypersecretion of the exocrine enzymes of the pancreas. So these enzymes enter the bile duct where they're activated, and together with the bile, they back up, known as reflux, and then they're basically causing pancreatitis. So everything is backing up. That's the main takeaway, and that's why you're having problems. All right. So for the acute pancreatitis, like I said, they've decided to call it either mild or severe. So under mild, they're saying the patient is acutely ill. You're going to be seeing things like edema and inflammation, but they're basically confined. That's a key word. They're confined to the pancreas. All right, so there's minimal organ dysfunction, in particular of other organs. Can resolve within 6 months. You may get things like hypovolemic shock, fluid and electrolyte imbalance, and sepsis. But that's if it progresses and starts kind of spreading much more than it should be. So usually confined to pancreas, minimal organ dysfunction, hypovolemic shock for sure, fluid and electrolyte imbalance. By the time you're getting things like sepsis, then that's severe. Then it's becoming severe. So I would put that under severe. So over here now, under severe acute pancreatitis, so then the enzymes have damaged your local blood vessels. There's bleeding and thrombosis that's going on. Your tissue is becoming necrotic, and the damage is extending into the retroperitoneal tissues, so it's more widespread. So the local blood vessel damage, you're going to see blood and thrombosis, necrosis, cysts and abscesses, other organs being involved, and then now you're definitely seeing all the other weird organ failure manifestations. So pulmonary insufficiency with hypoxia, shock, renal failure, and GI bleeding. all of these are going on. For you guys, I mean, if I wanted you to know if I wanted you to know mild acute pancreatitis versus severe acute pancreatitis, probably the thing that I would highlight under severe acute pancreatitis is the fact that you're getting the damage, the local blood vessels, and things are no longer just contained, and you're getting these systemic complications that are going on. And then maybe things like cysts and abscesses happening. Those are the things that I would be highlighting, and the multiple organ failure is going on. Whereas with the mild one, everything was kind of contained and it wasn't as bad. And once again, the enzymes we're worried about here are lipase, trypsin, and amylase. Those are the ones that are creating the problems for us. All right, so we've mentioned the fact that our pancreas has exocrine and endocrine secreting capacity. And the exocrine, we've mentioned the breaking down fats, proteins, and starches, right? So the problems that we're seeing in pancreatitis have to do specifically because of the proteolytic enzymes, in particular the trypsin. That's why we're getting the problems that we're getting. So the enzymes are released into the surrounding tissue, and the tissue is becoming inflamed. So they're digesting the surrounding tissue. So that's why we have an issue in pancreatitis. All right. So they're normally not harmful. They're minding their business. They're going where they're supposed to be going, which is basically the duodenum, and then they start doing what they're supposed to be doing. But if there are problems along the way that are causing issues like inflammation, etc., then that's why we end up with the pancreatitis, the inflammation that happens. So maybe there's biliary disease or there's obstruction, right? So here we're just looking at what can activate the enzymes. So maybe biliary disease or obstruction, maybe alcohol usage, right? Because alcohol is an irritant, so that's causing inflammation, right? The Coxsackie virus. So this apparently is an RNA virus. It causes hand, foot, and mouth disease. And apparently happens in infants, children, and kids less than 5 years old. They get weird manifestations like fever, mouth sores, skin rash. You can see things in addition like respiratory manifestations, and then maybe meningitis. And it's very easy to spread, especially with unwashed hands and droplets as well. All right, so these are things that can trigger your enzymes being released too soon. Trauma, surgical manipulation of the pancreatic duct. So maybe they were going in there looking around, and now you've released some enzymes. Things like mumps, all of these issues. They've highlighted biliary disease as being a problem, in particular gallstones. So that can cause a blockage. And then things basically, so I mean, it's a very confined space, a very small space. So one problem in one part of your body basically exacerbates issues in other organs in your body as well. You can think of this as under neuro, like ICP, like if you get like hematoma in your brain, right? You're supposed to get equilibrium, but now you're not getting equilibrium, and there's only so much space. So it creates problems in other parts of your body. All right. So gallstones can enter the common bile duct. They lodge at the ampulla vata, obstructing the flow of pancreatic juice, and then they're causing basically a reflux of bile, right? Then that will activate your powerful enzymes within the pancreas itself, and that creates the problem. Normally, the enzymes are supposed to end up in the duodenum, and then they can become activated and do what they're supposed to do there. But now they're getting activated too soon, too early. Keyword, too early, too soon, and not even in the right place. So you're getting things like vasodilation, increased vascular permeability, necrosis, erosion, and hemorrhaging. And remember, it depends on the how much of it is activated and what's going on. All right. So other causes of pancreatitis, so bacterial viral infections, mump viral infections, spasm and edema of the ampulla vata, blunt abdominal trauma, peptic ulcer disease, ischemic vascular disease, hypolipidemia, hypocalcemia, use of steroids, thiazide diuretics, oral contraceptives. All of those things have been implicated. Also after surgery, touching the pancreatic duct after surgery, maybe even hereditary pancreatitis. So all of these other things you just want to monitor closely as well. So knowing what you know about the enzymes and what they do, already you should know that there is a chance for that mortality can happen. So this is a true statement. So, patients could die from this because of the shock, anoxia, hypotension, and the fluid electrolyte imbalances that can happen. So we're still at 2 to 10%, but if you're the 2 to 10% and you die, well, that's not a good thing. So if you're lucky, you can end up with complete recovery, but you really want to figure out what caused it so that once you fix that, hopefully this won't be an issue for the patient anymore. All right, so here just a picture, so etiologic factors, so any of these things can cause pancreatitis, so alcoholism, biliary tract disease, trauma, infection, drugs, post-op GI surgery, and whatever else is out there. So you get activation of the pancreatic enzymes, you get the injury to your pancreatic cells, and then you're basically getting the autodigestion effects of the pancreatic enzymes. Everything is basically activated at this point. So trypsin apparently is primarily responsible for edema, necrosis, and hemorrhaging. Elastase, hemorrhaging, phospholipase, fat necrosis, lipase, fat necrosis, kallikrein. These are the other ones. So here we're mentioning more of the other types of enzymes that come from the pancreas. So kallikrein, edema, vascular permeability, smooth muscle contraction, and shock. So this is just a more holistic look at some of the enzymes. All right, so same picture that we looked at earlier. So here you're getting obstruction of the gallstones, and basically the pancreatic duct is obstructed. So remember, stuff is supposed to be moving forward and ending up in the duodenum. Is no longer able to do that, so everything is going back and it's getting activated. And remember also, so the gallbladder could be implicated, because if there's stones here, remember what happens with the bowel stasis, etc., backing up, and bile is doing weird things. So this could potentially become a really big problem. All right, so what are you going to be seeing in your patients? So things like severe abdominal pain, mid-epigastric region. So it's usually acute. So 24 to 48 hours after a large meal or alcohol consumption, it's unrelieved by antacids, because the enzymes are just doing bad things at this point. Abdominal distension can be rigid, nausea, vomiting, fever, jaundice. So remember, we talked about jaundice under the gallbladder already, right? Mental confusion, agitation, hypotension, possible respiratory distress, fatty stools, constipation, because once the bile also is backing up, not moving forward, not emulsifying your fats, that becomes a problem as well. So because everything is kind of out of whack, constipation is a possibility. If the fats that maybe are there are not being digested, diarrhea even could be a possibility. So it's literally anything here, but definitely fatty stools. So ecchymosis, bruising in the flank area, may also indicate severe pancreatitis. So that's a true statement as well. All right, so in terms of your assessment, you see your patient, you're maybe trying to rule out pancreatitis, so you're going to do your whole aggressive assessment. You're going to look at your risk factors. You're going to do your physical examination. You're going to look at your amylase and lipase, right? They're considered the gold standard of diagnosing for pancreatitis. You're going to see whether or not there's hyperglycemia. So remember, the pancreas is supposed to be doing endocrine as well as exocrine function. So your endocrine has to do with your insulin, right? And your insulin is supposed to be putting your sugar in your cells now, but now that's not going on anymore. So the sugar in your intravascular space is going to be elevated, okay? Elevated WBCs if there is an infection as a part of the inflammatory process, right? So all of that is going to be going on. So you're going to be doing other tests like x-rays, ultrasounds, basically to rule out any other types of gastric disorders. So when a patient also has stress, so your book may mention this, they may mention what is known as stress hyperglycemia that you may see in your patients. If you're stressed out, you're going to get a sympathetic activity that happens. You're going to get an increase in glucagon. Glucagon is going to increase sugar, right? Because it's going to convert glycogen to glucose because you are basically stressed out. So that's also a reason why you may end up with things like hyperglycemia in your body as well. So stress apparently does that also. All right. So you basically want to manage the pancreatitis. You want to relieve the symptoms. You want to prevent complications. So here is where the pain management comes in. So here we're opting for morphine and fentanyl and Dilaudid. We're not doing Demerol as much because they said apparently you can have CNS irritability and possible seizures. So once again, just know that that's out there in terms of the medications, but I do want to make the distinction. It's going to be different for each patient though. Because obviously if your patient that has pancreatitis is an old patient and then you're giving them things like morphine, then you just have to monitor them very, very carefully, right? So I think it's an individual basis, but you just want to know that when we were talking about gallbladder, we were loving Demerol more so. And here we're loving morphine and fentanyl, and this is always going to fluctuate and change. So depending on the stage, once again, there can be NPO, NGT needed for nausea, vomiting, abdominal distension. We may see things like paralytic ileus once again because maybe blood is not perfusing like it should be to the whole area. So enteral feedings only if you've assessed the patient properly, there's bowel sounds, and it's possible to feed them in that way. But for other patients, probably parenteral nutrition is the way to go. So either total parenteral nutrition or partial parenteral nutrition. And I will be making another slide later on today for TPN and the NG tube. Okay, and then the medications that are beneficial in reducing secretions, so they include things like Protonix, Nexium, Tagamet, and Zantac. All of these can be given. So these patients that have acute pancreatitis, they're definitely going to be in the ICU because they may have issues, right? Because especially if you have bleeding, because maybe your enzymes have done that to you and they've made it severe. Pancreatitis is not mild anymore, so you know that there's a potential for a blood loss, right? And just sepsis even. So you really want to monitor the patients closely. So you want to correct your fluid balance. You're going to be maybe giving them blood, giving albumin. They're going to be connected to hemodynamic monitoring. They may even be on an insulin drip to correct the blood sugar. You'll be looking at your ABGs. You're going to see whether or not they need to be intubated on a ventilator. All of that may need to happen. And then until basically a patient can become stable. So yeah, so it's going to depend on what your patient needs. After you've kind of revived them and they're okay, right? So initially we already mentioned they're going to be NPO, and then you're going to advance the diet as tolerated. Maybe they'll have drains because they needed to have a stent put in. So you have to monitor all of that in terms of nursing manifestations. Ideally, they're going to be in semi-Fowler's position. If they have a drain, you're monitoring your drains for any skin breakdown. And I'll talk about some of the drains that they can have later on. So no coffee, no alcohol for these patients. If there are particular medications that were an issue, like contraceptives or steroids, you're going to stop all of those, right? So it's patient specific, but you have to make sure you've done a really aggressive assessment of your patient. All right, so under acute for sure, pain related to inflammation, ineffective breathing pattern, imbalanced nutrition, knowledge deficit, non-compliance. Any of these would be at play. So the usual pain management modalities, which we've talked about, and usual respiratory modalities, which we've already mentioned as well. All right, so for the chronic, they've decided, like I said, to distinguish it by saying that here now you're getting anatomic and functional destruction of the pancreas. It's because you've been getting repeated attacks of pancreatitis. They're saying it's usually because of alcohol, and that this happens 50 times greater in terms of the incidence in patients who drink, and you're getting the fibrous tissue formation that happens primarily because of the obstruction of the pancreas, the bile ducts, and the secreting cells. All right, so smoking also a contributing factor for sure. All right, so here it's just different pictures showing you the different types of pancreatitis, so either calling them mild versus severe, and then just talking about the progression that can happen from acute pancreatitis, and then you're getting extra pancreatic manifestations, then you're getting cyst formations, then you're getting chronic pancreatitis, and now you're getting end-stage chronic pancreatitis. So the little spots are showing fibrosis, and then these little other lines are showing calculus formation. The other ones are showing necrosis. So just, a picture there. No need to memorize. No need to memorize. So recurring attacks of severe abdominal and back pain here. Now we're under chronic. High risk for opioid dependency, right? Because, what medications are we on now? So now we're favoring, what were we favoring here? We're favoring morphine, right? Dilaudid, and fentanyl even, right? So they could be at risk for opioid dependency, so you're watching them closely. You would be lucky if you had no pain, but some patients apparently have no pain. So once again, you're doing your assessment to see what's going on. I would be hard-pressed, though, to find a patient with chronic pancreatitis who is not in pain. Especially if you're getting necrotic tissues, because all of that is an inflammatory process. So for sure, you're going to be getting some type of pain. So you're going to see weight loss, anorexia, obviously impaired digestion, malabsorption, so fatty and foul-smelling stools, seeing things like diarrhea in addition. So once again, remember what the pancreas is supposed to be doing, and none of that is going on. All right, some of your diagnostic tests, so CT scans, ultrasounds, all of that is being done. Your blood glucose levels, so we've mentioned the fact that it could be hyperglycemic, so that's a possibility. Maybe with repeated attacks, your pancreatic cells are damaged, and now they're not producing insulin and glucagon, right? So all of that is a possibility. So remember, high levels of glucagon will increase sugar. High levels of insulin will decrease your sugar levels. But if things are not working properly, so it could be either or. So no insulin maybe, right, or too much insulin, whatever. So you just have to monitor. In other words, you're monitoring your patient very, very closely. So pancreas are not working properly at this point. So things are not what they should be. So you just want to monitor your patient closely. And then steatoria goes without saying. And then the ERCP is our go-to diagnostic tests. All right, so ERCP, so here just some extra information. So visualization of the pancreas, gallbladder, duodenum, common bile duct. You have the scope in the esophagus, and then contrast is injected to allow visualization. With this ERCP, you can also do placement of stents if needed, removal of blockages or even stones, cysts, and you can even do biopsies. So all of that can be done as well. All right, the ERCP, so continued, so NPO, consent, they can do this under conscious sedation, so meaning that the patient is awake, so you can actually talk to them and let them know about what's going on. You're monitoring for bleeding, pain, puncture sites. If stents are placed, patency of the stents that have been placed. You're looking for infections and peritonitis, right? Post-procedure. So all of that is part of your ERCP. All right. Some of your non-surgical management for pancreatitis. So telling them no alcohol, trying to manage the diabetes as much as possible, right? Whatever you need to do, find out what's causing it. We already said that alcohol is the biggest issue, so you want to make sure that the patients are not doing any of that. And then your other non-surgical management, so things like diet, right? Maybe they're giving medications, right? I don't know, things like yoga even, I guess, to kind of just make the patient be calm. Whatever your usual non-surgical management stuff we normally talk about in class, you can apply any of that here. Okay. Let's see, under the surgical management, they can do a lot of different procedures. I'll mention two. Your pancreaticojejunostomy. This is also known as a root NY. They're joining the jejunum to the pancreatic duct, and it's basically allowing drainage of the pancreatic secretions into the jejunum. And apparently that helps with pain relief, and it's beneficial in about 85% of patients. The other one is known as a pancreaticoduodenectomy. It's a Whipple procedure, and that one is also used to relieve symptoms. And there's a picture that's coming up in a little while. So these are primarily reserved for severe pancreatitis, or maybe in some cases where there may be cancer of the pancreas, and that's why they're getting pancreatitis. So this is really, really extensive types of surgeries here. All of these drains are there after the procedure has been done. Okay. All right, so diagnoses, same as any other GI conditions with particular manifestations or alterations specific for pancreatitis. So acute pain, ineffective breathing, imbalanced nutrition, impaired skin integrity, especially if there's drains in place. Right, fluid and electrolyte imbalances, disturbances, necrosis of the pancreas, shock, multiple organ dysfunction syndrome, any of these are considered your complications. And once again, you're just reading through your nursing process because it's the same for all of them in terms of management at this point. All right, so those are the key features under pancreatitis. So you want to get a sense of, okay, what are the digestive enzymes that are very problematic for me? What are the causes in terms of, is it a blockage that's the issue, or is it diet because of alcohol? Is it acute? Is it chronic? And what are my types of manifestations that I might see, right? And how am I treating this in terms of what are some of the surgeries I can use, right? Yeah, so really, guys, it's the same information, but now we're just focusing on a different organ, and it's a pancreas this time. And now maybe there are unique manifestations like high sugar levels, stuff like that, all right? But if you get a good understanding of the foundation, then all of this you can unpack, and it's not going to be that complicated. All right.